Hi, my YouTube viewers. How are you? Today I'll discuss about breast problems. The most common clinical breast problems include breast mass, breast pain, nipple discharge, and breast infections. Breast mass. A breast mass is defined as a palpable area in the breast that may be either benign or malignant. When a woman presents with a palpable breast finding, a thorough history and physical examination needs to be performed. The history should include a thorough review of the patient's medical problems and any risks, any risk factors associated with breast cancer. In women younger than 35 years with no family history of premenopausal breast cancer or other risk factors, ultrasound is an appropriate initial imaging approach. Uh, but in women aged 35 years or older, the initial imaging approach to a palpable mass should include mammography and ultrasound. Actually, the definitive diagnosis of a breast mass is confirmed by core needle biopsy. Sometimes FNA may be appropriate alternative. Ultrasound can further categorize the mass either cystic or solid. Uh, Cysts that are well circumscribed without septations or debris and teen world referred to as simple cysts. But if there are septations with potentially a solid component or TQL, we call it complex cysts, and these cysts have risks for malignancy. Treatment-wise, or the approach, as you see, this is algorithm for simple cyst approach. Uh, if and the woman has asymptomatic simple cyst with classic benign imaging features, uh, this cyst does not require intervention other than reassurance. But if symptomatic, this can be observed or aspirated using ultrasound or palpation guidance. If the cyst aspirate is bloody in nature, it should be sent to the cytopathology laboratory to rule out possible malignant disease. For complex cysts in general, tissue biopsy is warranted. Breast pain, uh, we call it mastalgia, mastodynia, or idiopathic breast pain, and this is a common concern. Actually, it's rarely representative of a breast cancer. In general, two-thirds of patients present with cyclical breast pain, and the other one-third uh, breast pain is unrelated to the menstrual cycle. Cyclical breast pain is associated with hormonal changes during the menstrual cycle and occurs the week prior to the onset of menses and dissipates once menstrual flow is established. Cyclical breast pain is typically bilateral and involves the upper outer aspect of the breasts with radiation to the axilla or down the arms. Non-cyclical breast pain is more frequently unilateral and variable in its location in the breast. Treatment. Initial therapy for idiopathic breast pain includes lifestyle changes, use of supportive garments, a low fat, high carbohydrate diet, and elimination of caffeine and nicotine. Analgesics, oral contraceptives, and primrose oil can be used. Uh, Most of patients respond with this treatment, but about 5% of women will still have debilitating breast pain despite lifestyle changes and mentioned therapies. For these women, therapies like danazole, tamoxifen, bromocriptine, and gonadotropin releasing hormone agonists can be considered. Nipple discharge is the first step in evaluation of nipple discharges to determine whether the nipple discharge is physiologic or pathologic. Physiologic discharge is non-spontaneous or elicited by manual compression of the nipple. It involves multiple ductal orifices and present in both breasts. The discharge is commonly white or clear and usually negative on occult blood tests. In contrast, pathologic nipple discharge is spontaneous, present in a single breast or single ductal orifice and positive on occult blood examination. After physical examination, history and physical examination, uh, no further workup is required in women who have physiologic discharge, and these women should be advised to avoid manual compression of the nipples. Imaging evaluation is indicated for patients with pathologic nipple discharge, and this includes ultrasound for patients older than 30 years. Mammogram also recommended. In patients with an imaging abnormality, biopsy should be considered, and additional diagnostic tests like ductography and ductoscopy can be done to identify the specific site of the ducts. Treatment, if a malignancy is identified, the etiology of pathologic nipple discharge should be managed according to the appropriate cancer surgery therapy. But in the absence of no malignancy, terminal duct excision can be suffice. Breast infections. Breast infections can be classified into lactational and non-lactational. Lactating breast infections occur commonly during the initial 6 weeks of breastfeeding and during the process of weaning. In the initial stage of infection, mastitis or cellulitis is typically found with associated pain, erythema, induration, and fever. And the incriminated organism is commonly Staphylococcus aureus, and this uh, breast infection can be treated with pain control and antibiotics like dicloxacillin. Uh, and with this treatment, the mastitis should improve within 24 to 48 hours. After that, if the symptom or the fever persists, abscess should be considered. Non-lactating breast infections can present as periareolar abscess or less commonly peripheral abscess, and this abscess can be treated with needle aspiration if the abscess is small in size, but incision and drainage is indicated for larger as well as deeper abscess. And thank you, the viewers. And if you like the presentation, please thumb up and subscribe for my channel. Thank you. Bye.